arteriovenous shunts. Okay, of the macroscopic vascular anatomy, the renal artery divides into segmental arteries, which then divide in the vicinity of the pyramid into interlobular arteries, which then go along the sides of the pyramid as arcuate arteries, and then they throw off further arteries that reach up to the renal capsule. And if you have Doppler and you turn on your Doppler, it gives you an idea of how vascular the kidney is. The whole kidney lights up like a big vessel. The whole kidney lights up, and everybody has probably seen this image on their own machine if they have a Doppler. This has not been doctored. This has not been too over processed. This is something that you tend to see whenever you turn on a Doppler in a normal kidney. Okay, so we must remember that we have segmental arteries, interlobular arteries, and arcuate arteries when we are looking at the kidney. And so these vessels can appear as linear, frankly vascular looking structures in the sinus, so you have no problems here. You have this very vascular looking structure in the sinus, and probably nobody would be mistaking this for a renal stone. Now things are becoming slightly more complicated. Now if you have a good machine, you can probably still make out that this is a vascular structure. Okay, but if the patient is difficult, this thing you would not be able to see the whole wall of the, or a big an extended segment of the wall of the vessel. You might just see small bits of the wall which are orthogonally presented to the ultrasound beam, and these can then appear as small specks, usually at the periphery of the sinus, and then these have the potential of turning into a concretion in the proper clinical setting. So you need to be careful about this. If you have a reasonably good processing power in your machine, you can probably try different frequencies, or you can try tissue harmonic imaging. For example, in this patient, where you have these ill-defined echogenicities here, which might be concretions, on tissue harmonic imaging they become vascular as they are. Okay, so one of the ways that these present to you are as tiny echogenicities at the periphery of the sinus, So these are more likely to be vascular rather than actual renal stones, not concretions, just vessels which are being hit at a particularly strong angle by the ultrasound beam and are reflected as such. Okay, so we have another patient with a number of echogenicities at the periphery of the sinus and along the pyramids, which are again probably vascular. Arcuate vessels can be seen occasionally. They can calcify, and then they do occur and they do appear as echogenicities at the bases of the pyramids, and this is where the arcuate vessel is. This is an arcuate vessel, and this is calcification in an arcuate vessel. And you have now in this particular patient a series of thread-like echogenicities at the bases of the pyramids, which are just calcifications in the arcuate vessels and not renal stones. You see, these are at the bases of the pyramids, somewhere in the center of the cortex or towards the periphery of the cortex. Okay, so you also have a large number of non-vascular reflectors. They can be part of the normal anatomy, or they can be part of some other process, some other pathological process, or a physiological variant that might be present in that particular patient. So you can still have non-stone echogenicities which are also non-vascular in origin. Okay, so you can have prominent papillae with hydronephrosis. Obviously you probably have obstruction somewhere else, but you have these papillae projecting into the dilated sinus, and then the tips can become very echogenic due to certain reasons, and they can be mistaken for stones. But you need to recognize that this is a location where you will get tips of the papillae projecting into the calyces and appearing echogenic. Okay, Angiomyolipoma is another echogenic. It's akin to the hemangioma of the liver. Benign, you need to look at it, keep following it up, but probably don't worry about it too much, and fairly easy to diagnose on ultrasound. and this appears as an echogenic area within the renal cortex. These are usually very vascular, and if it is biggish, and if you have Doppler, you can look at the vascularity. But when you do find a relatively big size angiomyolipoma, you need to follow it very carefully, because occasionally significant tumors of the kidneys can appear this way also. But junctional parenchymal defect is another pitfall. It appears as a triangular depression in the renal contour. It can be filled with echogenic retroperitoneal fat, and sometimes you have a line, the junctional parenchymal line, which extends from the periphery towards the center. And you can have areas which are more echogenic than the rest of the line, and these can again mimic small renal stones and give you the opportunity to create concretions. Okay, milk of calcium cyst is another potential pitfall. You have a cyst, you have echogenic material in it. This might shadow, this might reverberate, and this can confuse you with renal stones. But if you turn the patient over, the calcium crystals will gravitate to the dependent portion again, and that is the giveaway. Okay, so milk of calcium cyst is something that probably you are coming across quite frequently, and probably some of you are not thinking on the lines of having a milk of calcium cyst in the renal cortex. Another small milk of calcium cyst, you have a cyst, you have this small echogenic material which has gravitated to the dependent portion in this particular cyst. Nephrocalcinosis, again very dramatic pictures with echogenic medullary pyramids. These can start as the Anderson-Carr process, where you have a line of echogenicity at the periphery of the pyramids, and this grows inside and then gradually fills in the whole pyramid. These can shadow, but the location is usually enough to allow you to make the diagnosis of medullary nephrocalcinosis. Okay, in the very young, in the infant, you can have transient increased echogenicity of the pyramid. This is due to precipitation of something which is the TAM Horsfall protein. The immature kidney cannot excrete the TAM Horsfall protein, and it precipitates in the pyramids. But if you just rescan after 2 or 3 weeks, in most of these cases the pyramids will have reverted to their normal hypoechoic state. So this is again a pitfall that you should be aware of. Of course, you can have foreign bodies in the kidneys, you can have catheters, and this is a Foley catheter bulb, and you can have drainage tubes and things like that, and they can be confused with, but I don't suppose anybody will be confusing this rounded structure for a stone, at least I hope not. Okay, so you have another drainage tube, a ureteral catheter within the kidney itself, and of course this can perhaps be mistaken by somebody to represent stones. So just to recoup, we concreate because we have patient pressure, we have peer pressure, and unfortunately a lot of us are involved in a single modality practice. If you're doing ultrasound, you're only doing ultrasound, and then you tend to see everything from the eyes of your ultrasound machine, and you want to diagnose everything with ultrasound, which is probably not a very nice thing to be doing. You need to know what other modalities are available, you need to know what are the advantages of other modalities, and you need to know where you are stronger than the other modalities. So, and you need to realize that medicine is a very, very dynamic science and an art, and things keep changing very rapidly, and you need to keep up with what is happening around you. Now, in this particular case, the algorithms that were recommended for diagnosing renal stones have changed almost on an yearly basis during the early 1990s. In 1990 it was IVU, in 1992 IVU was replaced with KUV and an ultrasound was added. In 1993 IVU was again added to the scenario, to the algorithm, and in 1995 IUV was replaced with helical CT. And perhaps helical CT these days is the modality of choice for diagnosing small renal stones, and renal and ureteric stones, as you can see in this patient. You have these tiny echogenicities, tiny dense lesions on these reconstructed images from a helical CT. So obviously not all of us have the luxury of ordering a helical CT in all of our patients who come to us with lumbar pain. But what we can do is, we can take a good history, we can do a reasonably good physical examination. There is no reason why a sonologist cannot do a physical examination. I think that there is no restriction on that. And we can add the information that we get from a KUB and from an IVU, and we do an ultrasound, and with the combination of all this input, perhaps we will be more accurate. So the final slide is that we must realize that ultrasound has its limitations. We need to explore the merits of other modalities. We need to know the artifacts, but most importantly, this is a question of personal integrity. We should not report what we do not see. Thank you very much.
Thank you very much, Dr. Duresavi.
All the guest speakers are invited to be seated on the stage, because we have some people from different press, some newspapers. So I would like to invite all the distinguished speakers, please come for a few moments on the stage so that we can have press coverage. So our next speaker will be Professor Dr. P.K. Srivastava, who is Head of Whole Body CT Scan Unit, Department of Radiotherapy, King George Medical University, Lucknow, India. He is founder of Indian College of Medical Ultrasound, Fellow of Indian College of Radiology. Professor Srivastava is also President-elect of Indian Federation of Ultrasound in Medicine and Biology for year 2004 and 5. He will be presenting a talk about interesting color Doppler cases. So I would like to invite Professor Srivastava for his talk. After the things are finished, each of 20 minutes, so you can sum up the time which is left for your lunch.